And now on behalf of Division of Trauma Surgery and Critical Care, myself, Dr. Sushma, I extend my warm greetings to all the senior faculty members who are present here, my faculty colleagues, residents, and those who have joined us on YouTube. Welcome to the CCR. So we'll be presenting a COVID warrior's victory over life and limb. This was a patient who came to us with extensive soft tissue injury during a time when there was extensive lockdown and people were housebound, but trauma never stopped. And in fact, we saw more of high impact and high velocity injuries during that time because there was less congestion on the road. So a team of residents from Division of Trauma Surgery and Critical Care, Dr. Ramesh and Dr. Pranay, from Radiology, Dr. Sharad, from Critical Care, Dr. Ayush, and Dr. Ajay from Orthopedics, and Mr. Manish from Physiotherapy will be presenting the case. Ramesh.
Good afternoon, everyone. So I would like to take you all back to the era of first COVID wave when the entire nation was under lockdown. And on one such night, a 25-year-old young police personnel met with an road traffic injury on 22nd of May. He was initially taken to a nearby tertiary care center, which due to the COVID restriction could not admit the patient, and after initial management was referred to All India Institute of Medical Science. So on presentation, patient had the mechanism of injury was patient underwent a road traffic injury. He was a motorized two-wheeler who was hit by a truck. The suspected injury was a polytrauma case with suspected injury to the head, abdomen, pelvic fractures, and long bone injuries. Patient was alert on presentation with a heart rate of 130 beats per minute, a BP of 90 by 54 millimeters of mercury, and a respiratory rate of 22 cycles per minute. After initial resuscitation with blood and blood products, and after dressing and suturing of wound, patient was referred to us. And on primary presentation, the patient airway was patent, his cervical spine was stabilized. Patient was breathing spontaneously with a respiratory rate of 18 beats per minute and a saturation of 99% on room air with bilateral equal air entry, and the chest compression test was negative. The heart rate was 130 beats per minute and the BP was 90 by 54 millimeters of mercury. His pelvic compression test was positive, for which a pelvic binder was applied. FAST was done, which was positive in the pelvis. Patient was E4, V4, M6 with a bilateral equal and reactive pupil with restricted movements of bilateral lower limb. Hypothermia was prevented. Adjuncts to the primary survey, the chest X-ray was essentially normal. The FAST was positive in pelvis and the pneumoscan was negative. The pelvic X-ray, as shown in the diagram, shows a pelvic diastasis with vertical shear fracture with a displaced right iliac blade fracture and a right SI joint disruption with also bilateral proximal femur fracture. The initial ABG showed a severe metabolic acidosis with a lactate of 4.3 and a base deficit of minus 6.4, corresponding to at least class 3 hemorrhagic shock. The patient was a responded to the fluid and blood therapy, and then in the secondary survey, we can see that extensive soft tissue injury, which was there is something. Thank you. Yeah. So on the secondary survey, there was an extensive soft tissue injury involving the right lower abdomen, the right pelvis, and bilateral lower limb with a suspected non-salvageable right lower limb. On the secondary survey, we can also see that there was a there was a closed both bone fracture of the left lower limb. We also want to highlight here that the patient was having a severe crush injury, but he was sutured from outside. This unfortunately could have been avoided because it compromises the blood supply to the already threatened limb and also increases the chances of compartment syndrome. In the adjuncts to the secondary survey, the patient underwent a NCCT head and C-spine and CCT torso, which will be discussed by our radiology colleague, Dr. Sharan.
Good afternoon, everyone. We have done a CCT torso for this patient, and the chest, there was no significant findings, only a minimal effusion was there. And in abdomen, the solid organs are normal, and lower down, there is a pubic pelvic fracture involving right iliac bone, superior pubic rami, inferior pubic rami, with the displacement of fracture fragments downwards and laterally. And there is also sacral fractures. This pelvic bone fracture involving right iliac bone. And this is sacral bone fractures. The upper four sacral bones are fractures, vertebra fractured, involving zone 3, zone 2, and also zone 1. And there was a loop of bowel loop which is seen extending up to the wound, causing the bulge. And there was a minimal hemoperitoneum in this patient. So we could not rule out bowel injury in this patient confidently. And there is also there is a abrupt cutoff of right external iliac artery. And we also could not visualize distally approximately 5 centimeter from the bifurcation. And distally also we can't make out external iliac artery and external iliac vein. So there is a fracture. Final impression was there was a pelvic bone fractures involving right iliac bone, SPR and IPR, and sacral bone fractures with extensive soft tissue injury with air in the skin and subcutaneous tissue. And also there is a abrupt cutoff of external iliac artery on right side. And there is minimal peritoneal hemoperitoneum and minimal right-sided hemothorax. And we also could not confidently rule out bowel injury in this patient because there was a loop of bowel loop which is seen causing bulge at the wound site on right iliac region. So we could not confidently rule out bowel injury.
So on further evaluation, the patient had a low hemoglobin and a hematocrit which was on the lower side, suggestive of hemorrhage, and a total count which was elevated, and a borderline elevation in the creat and potassium with a positive urine for myoglobin. So the injuries which were as told by the radiology colleague, he had a vertical shear fracture of the pelvis with bilateral shaft femur fracture and left both bone fracture, and blunt vascular injury to the right external carotid or right external iliac artery with bilateral blunt trauma chest with minimal hemothorax, and right ulna fracture with a injury severity score of 22 and a new injury severity score of 27, which is representative of a severe injury. So our working diagnosis was pelvic fracture with bilateral femur fracture, right external iliac artery thrombosis with right hemothorax, and crush syndrome with suspected injury to the bowel. So what were the initial challenges in the management of this patient was the first and the most life-threatening complication was the crush syndrome. We had to attack it at the first time. And also it was complicated by the COVID positive status, and we had to consciously take a decision to protect his life over his limb. So just to brush up on the topic of crush syndrome, crush syndrome is also called as traumatic rhabdomyolysis. So it is a systemic manifestation of muscle cell damage with release of contents into the circulation resulting from pressure or crushing. The mortality rate of crush syndrome can vary up to about 50%. So the pathophysiology is that basically because of the crushing, the sodium and water enters into the cell leading to systemic hypovolemia, and the contents that come out of the cell basically because of the sarcolemmal damage, there is potassium, myoglobin, creatinine that comes out and causes a polysystem involvement. So the basic management of crush syndrome is basically IV fluid resuscitation. In-hospital management should adhere to the principles of ATLS with ABCDE as the priority. ECG and electrolytes should be monitored. A urine output should be targeted at least 200 ml per hour. So the unique challenge in this patient was, although the crush syndrome involves aggressive fluid resuscitation, we had to restrict the fluid because he was also COVID positive. So there was, apart from these issues, we also faced a lot of logistical issues because it was the first case done by in our COVID operation in trauma center, and there was restricted communications and long operative period time in PPE. So we went ahead with operative procedure on the same day, about 7 hours, 5 hours post arrival, with right-sided emergency hemipelvectomy with exploratory laparotomy and diversion end sigmoid colostomy. The operative time was about 5.5 hours. So as you can see in this, the mortality risk with one condition is quite high, but this compounded with multiple injuries to this patient to more than about 60 to 70%. Once after the surgery, the patient was shifted to ICU on inotropes and on mechanical ventilator. The further ICU course will be discussed by Dr. Ayush from critical care.
Good afternoon, everyone. Just wanted to highlight some of the issues that were faced in the critical care management of this patient. The patient went into sepsis followed by septic shock early in the postoperative period on postoperative days 1 and 2. He grew Acinetobacter on his blood cultures and Pseudomonas from his tissue cultures, mechanically ventilated for a total period of around 9 days. There was the risk of crush syndrome in this patient as evidenced by the hyperkalemia and the myoglobinuria. And although the kidney function was adequate in this patient, giving liberal fluids was a challenge because of the underlying lung status. From a COVID perspective, the disease severity was always mild, with the oxygen requirement never going beyond 40%. It's also important to remember these were early days of the pandemic. Treatment protocols were not very well defined, so that added to the complexity of management. The extensive nature of surgery mandated a lot of blood loss, and he required multiple blood transfusions. There was a risk of thromboembolism, both from the immobility brought by surgery and from a COVID perspective. Nutrition was managed via the enteral route, and the extensive nature of surgery also mandated some positional care and some dressing issues. Just to sum up his course in the ICU, he was admitted on the 23rd of May, and he was mechanically ventilated for a total period of 9 days, initially on volume control ventilation, followed by pressure support, oxygen requirement going up to 40% itself. Maximum noradrenaline support he required was around 10 mics per minute. Antibiotics were tapered as per the sensitivity reports, and he responded quite well to that, as evidenced by the TLC counts going from a high of 18,000 up to 8,000. The preoperative hemoglobin that we received was 11, and it dropped to a minimum of 6.8, so he required multiple transfusions for the same. Eventually, he responded to this line of management, and we were able to taper off the vasopressors, and we were able to extubate him to face mask, followed by he was eventually discharged on day 12.
The next challenges after the initial risk of the crush syndrome was averted was that we had to counter the sepsis. It was a hospital acquired infection, multi drug resistant Pseudomonas and Acinetobacter, followed by we had to save the left precious limb. It also had multiple injuries. Third thing that we had to keep in mind is the big wound on the right side after the pelvectomy. Fourth thing we had to think about was the nutrition, which was already described, that we started initially on enteral therapy. Even if he was on I know the beginning started on enteral therapy, and at last we had to counter the deconditioning syndrome. So what is a deconditioning syndrome? A deconditioning syndrome is basically a cluster of symptoms which happen due to decline in the functional, in the physiological, in the psychological status of the patient because of prolonged immobilization and decrease in the muscle mass of the patients. These were the challenges which came subsequently in the management of the patient. So while the critical care issues were being managed, we had to manage this wound, which was obviously a source of the sepsis. So this was day 5 of the injury, in which the culture came out to be Pseudomonas positive, and with multiple chemical debridement, bedside chemical debridements, 3 times surgical debridements under GA, we achieved a reasonable amount of infection control up to day 15. On day 19, the patient came out to be COVID negative, and we shifted him immediately to the non-COVID ward for further management. Now here we can see the wound progress, where you can see this is on the day 5, that the status of the wound on day 5, and by day 25 we could achieve a reasonable amount of sepsis control and a good graftable tissue. Now we wanted to consolidate this gain that we have achieved with the 25 days, so we were considering about early wound closure. So we were mulling about the options. These were the options that we had to cover the wound, early wound. So the first option of autograft was rejected because the patient was still in a catabolic state. We did not want to add to the surgical load of the patient, and also the limb was very precious. So we did not wanted another wound over that like at this stage of the at this clinical stage. Also, we did not think about taking the STSG from the back because the patient already had a stoma, and it would have been very difficult to nurse him in the prone position because of the unstable pelvic fracture. The second option of an allograft from his family members was rejected because at that time the COVID was very high, so we did not wanted to expose the relatives of the patient only because of taking the graft. The third option, which we have used 2-3 times before, is that of a cadaveric graft. It also could not be procured because of the travel restrictions that were in place. So we were only left with the option of a artificial skin, that is the Integra. The only disadvantage that it had was a huge cost that it has. So this piece of Integra, which is 20 into 25 centimeter dimensions, costed around 3,78,000. Now, what is the Integra? Integra is also loosely called as a artificial skin. It is basically a dermal regeneration template. Consists of two layers. Is a composite artificial skin graft in which the upper layer is a silicon membrane and the lower layer is a type 1 bovine collagen. And the good thing about this is it lets the skin heal without a scar tissue, and it lets the native tissue grow into the wound and provides a scaffold for it without causing any local reaction. So this is the wound. On day 33 we posted the patient for surgery, and this is how the Integra was applied. Now we added a negative pressure wound therapy to the Integra, and this is what we achieved on day 53. We had to remove the silicon layer, has to be removed on a later date. So on day 53, the silicon layer was removed from the wound, and this is the status of the wound at that time. And on day 60, this is what the wound was looking like, which had a very good base for a STSG graft. At this stage, now we have taken the graft from the autologous side, that is the left lower limb, and this is the STSG that we could. Now this is the wound with which he came initially, and this is what we could achieve after 93 days of surgery, 93 days in hospital stay, 8 days on ventilator, 19 days of COVID stay, total 55 units of blood and blood transfusions, and total 8 surgeries. Still after the discharge, these rehabilitation issues were pending, like because of the prolonged bed ridden status, he had a cachexia, and his left limb also showed muscle atrophy. So we had to strengthen the limb and to weight bear. And also he had a stoma which had to be reversed. And because before the stoma could be reversed, we could not put a prosthesis. So all these issues were still pending. So we continued teleconsultation of this patient, and he was advised on the physiotherapy over teleconsultation. Now I will request the physiotherapist to explain what the challenges he faced.
Good afternoon, all faculty members. I would like to thank Sushma for me to present this case for regarding rehabilitation. Initially, what problem we faced was like initial patient was having very much pain, because of which movement was restricted. So restriction and pain was very much uh, 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 at that time. So what we did is we gave TENS initially. TENS would not reduce pain drastically, but it will give an initial movement for you to have a little movement. So we gave 15 to 20 minutes of TENS. After then we can start little movement. So what in the first movement what the patient is doing is after giving some TENS like 15 to 20 minutes, we started muscle energy technique. Muscle energy technique acts like once we ask the patient to get a maximal contraction, after then due to autogenic inhibition and weight on the downside and gravity also assist. So initially the capsule would relax and length would increase, and in long term it will increase the range, and even when range is increased, we can ask the patient to have weight bearing as well as strength would also increase. After that it has to be maintained. So for maintaining it, we did regular passive movement by passive machine and all, and we continued with that.
So continuing the rehabilitation, we readmitted the patient almost about 1 year after the injury for stoma reversal. On examination, we saw that his left knee has developed a contracture, for which contracture release and physiotherapy were instituted. I'll ask the orthopedic SR to tell us about the orthopedic interventions and orthopedic challenges he faced.
Good afternoon, everyone. After sacrificing the right lower limb, the fractures left to manage left to manage were the subtrochanteric fracture of the left femur and distal third shaft fracture of the left tibia. The index procedure, suprapatellar interlocking tibia nail was done and proximal femoral nailing was done 48 days after the trauma. And after 388 days after injury, the contracture release of the of the left knee and mobilization of left hip under anesthesia was done to increase the range of motions. The issues after the index surgery were the left hip and knee stiffness, delayed fracture union, and extensive physiotherapy and continuous passive motions after quadriceps release, which was the second procedure. The challenges faced by our team was the upper tibial pin tract infection, which was used to primarily stabilize the fracture in the emergency. Definitive surgery was done around 48 days after the injury, which led to difficult close reduction of the fracture during fixation. After fixation, there was discharge from the proximal screw site, which was very much near to the upper tibial pin tract site, which was already infected, and which thereby led to and thereby there was later on there was stiffness in the ipsilateral hip and knee joint due to the prolonged immobilization after injury. Because of the stiffness, a complete release of the quadriceps and knee arthrolysis was done to increase the range of motion. After the stiffness was set in, the knee was fixed in around 10 degrees of flexion and range of motion was 10 to 20 degrees. After quadriceps release, the range of motion was increased to 90 degrees. Z lengthening of the rectus could have been done to increase the flexion, but it would have led to extensor lag and weakness of the quadriceps, thereby leading to gait difficulties. What else could have been done? External fixation for fracture femur and both bone leg could have been done to stabilize the fracture early, which would promote early range of motion and maintenance of length and alignment of the fractures, which would have made the definitive fixation much more easier. But external fixation would have led to pin tract infection, increased chances of infection of intramedullary nails, and in subtrochanteric fractures, it is very much difficult to apply external fixation because the proximal fragment is much smaller to accommodate two pins. And the patient also had fracture ulna, which was managed conservatively. So we could have done open reduction, internal fixation, and plating for fracture ulna to promote early mobilization of the right upper limb. But there was chances of infection as the fracture ulna was compound grade 2. Thank you.
So this is what we could achieve after 1 year and 3 months of post-injury. We were successful in making him stand and walk after 1 year and 3 months of injury. And to summarize the treatment, what we did was after injury, when we received the patient after 14 hours of injury, we did a primary survey and resuscitation as per the ATLS protocol, which is a structured approach in which the examination, evaluation, and resuscitation goes side by side. Followed by that, we moved to the secondary survey, which is basically head-to-toe examination. CECT is a part of that to rule out any associated injuries which requires immediate attention and may cause to the morbidity and mortality. In this case, it was a suspected bowel injury, which could have changed the prognosis. After completing the secondary survey and having a throughout idea, we prioritize the treatment with emphasis on physiological restoration rather than an anatomical correction. So we should, in this case, we treated the crush syndrome with priority, and also it has to be a staggered approach. We don't need to treat everything at the same time. This avoids the second hit in this patient. The fourth thing that was very important in this case was sepsis management and sepsis prevention. Serial debridements and a culture-based antibiotic in the early part of the care helped us a lot. And to consolidate the gains, we did an early wound coverage. That too had a tailored approach. We did not give any additional physiological stress to the patient. It was a tailor-made approach specifically for the patient. And last but the most important part is the rehabilitation, which consists of the psychological assessment and motivation, early restoration of the bowel continuity, a customized prosthesis, and at the end we had to have a target of achieving a functional independent individual who can contribute to the society rather than a person who is lying on the bed and just is not independent. So that is the functional outcome that we expect. So, to end the presentation, I would like to say that to consider this as only a case will be a very understatement, and we would like to emphasize the journey on which the patient undertook and came victorious. Also, what we could not show you in these slides is the pain, the suffering, the grit, the determination, the chutzpah, the uh, struggle that he underwent, and it is nothing short of awe-inspiring. Thank you so much.
Thank you so much. So house is now open for discussion. Yes, sir. The with the police dress. So actually, he sent it later on, but he has not yet joined the job. Probably he'll be given a desk job because he's still doing his gate trainings. No, no, not recover, not up. Yet to send his pictures after recovery.
Ma'am, very well managed case. My question is, since you use this Integra and it gave very good results, but in a country like ours, there are patients who would not want such a skin because of its bovine origin. So is there any other option in patients who do not want a skin of bovine origin in such a case where you do not have the option of allograft or autograft? My questions come from my experience when I was working in the UK in my shoulder fellowship, where we used to use a lot of bovine patches for shoulder reconstruction. And I had a specific patient from a specific community who said that no matter what you do, I do not want a shoulder. I don't want this shoulder if you are putting in bovine skin. And luckily, we used to get denatured human skin there, which used to come in a pack, which did not come from a bank, and we could use that. Is there an option, any such option for our patients in India as well?
See, most of the people now are using cadaveric skin graft. Dr. Sabapati in Ganga Hospital, he is procuring cadaveric skins. His residents go out to the periphery, procure that cadaveric skin like the cornea, and they are distributing, and you can buy it at a very nominal rates. So that is one. Dr. Bilwani in Bombay, he is also providing cadaveric skin. So that is one and the easier option. Other option which we are very commonly using in our patient is allograft. We catch hold of the relatives of the patient, they donate the skin. That skin we are using. Third thing is that amniotic membrane, yes, is coming up, and Dr. Abhinav in our department has been doing that project, wherein we have recycled the and denatured the amniotic membrane through the stem cell facility, and that skin amniotic membrane can be, I think, the VOG and can be a easier and simple solution for a country like ours. Integra definitely is a very costly affair, but I think if more and more people will be start using it, then we can use it. The best part with the Integra is that it can be applied over the periosteum and the bone as well. Like other things you cannot apply on bone and periosteum, but it can be applied over there.
Thank you.
Yeah.
Once we have our skin bank, which probably Dr. Manish is wanting to have in the burns and plastic, because he'll be needing it more, then I think even that would be taken care.
It should be incorporated in the Orbo program, I mean harvesting skin. Yes, ma'am. Not yet. It is not yet incorporated in our Orbo program of the institute. Because our skin bank is not ready. So Dr. Manish is in the process of establishing a skin bank in the plastics department. After that, we can. Yeah. See, otherwise also we have been managing hemipelvectomy cases, but unique was that he stayed maximum of his time of debridement in critical care ICU in the COVID. So I would like to get comments from Dr. Richa and Anjan sir to give his feedback.
Basic issue was that we must remember he went into the first time when COVID.
Yeah. And sir, if you
I think
remember
what
the
happened, if you attended the meetings in the auditoriums, nobody was willing to intubate her. That was a kind of fear of death which we had, each one of us. And hats off to all the faculty members of my department. And I saw to it, they were all young chaps and chappies who went in. We saw to it because there were all kind of things going wrong. Put a polythene bag, put a plastic box or whatever, but nothing happens. You can't intubate through a plastic box. You can't do it. You have to face it. I think that is what is going on.
In fact, the first resident of anesthesia, he fainted there.
Yes,
So he had to be
anybody.
brought out,
I
and
have a
another one
list
had to. Yes.
I
sir.
have a list of patients and our sisters who fainted in the COVID setup because of various reasons. And one issue was fear of death. Let's be very honest. There is a out- no, there's a chap, there's a faculty member. I don't forget his statement. He went in, he said, "Sir, मैं आज अंदर जा रहा हूँ, Sunday का दिन था. Sir, मेरी इतनी सी बेटी F type से बाहर आई, कहती, come home safely, dad." अरे, मैंने कहा ऐसा क्या होता था? Sir, ऐसा ही है मेरे घर में. Everybody thinks that I will not come back home. So this is classically giving GA at that time was committing suicide. Now we can think in retrospect, nothing happened. If at all, it's nothing. That was what is more important. The same was true in the ICU. I'm sure Richa and Kapil were there. They were already. We earlier had thought that you were going to chop off both the limbs. I'll be very honest. Because at that time, the
Yes,
issue
sir.
was do something fast and come out.
Yeah.
Even the surgeons would face the same thing. Now, why do you forget about the surgeons? 5 hours inside. So I think in the hindsight, you could say you did just chopped out one limb. Because doing both at the same time would have been the fastest bet. But I think you did the right approach. Richa, you want to add anything?
Thank you.